My name is Mike Chernew, and I'm the Leonard Schaefer Chair of Healthcare Policy at Harvard Medical School. I'm an economist by training. I study healthcare spending broadly. What that means in practice is I study different ways to pay providers and different ways to design insurance benefits to change the incentives that patients face to promote consumerism and stuff like that. The brief that we wrote, and in this case, we is my colleague Limor Daphne and Max Pani, looks at regulating prices in the commercial health insurance market.
Can you tell us what the issue is that you're looking at and what you're diving into in this brief?
We're looking at high prices for healthcare in commercial healthcare markets. People may not realize that there's very wide spending within markets, prices within markets in the commercial sector. There's wide variation in prices across markets in the commercial sector, and those prices are almost uniformly, not quite uniformly, but the vast majority of them are much higher than, for example, Medicare would pay. And they've been rising over time. So there's a lot of concern about those prices. It would be one thing if we thought the increase in prices was related to better quality or other things that we broadly want, but I think there's just a well-known and growing body of evidence that there's a lot of consolidation in the commercial market, actually in the provider market for healthcare services, and that consolidation drives up prices with very little evidence of better quality. And so there's a question about what to do with those sort of competition failures and the manifestation of that to high prices.
So Marty Gaynor and I are going to talk about antitrust enforcement as a tool to lower prices. You're going to say antitrust enforcement, and what is the and you're proposing?
Yeah, I am going to say we should do antitrust enforcement and antitrust enforcement, not to say anything about your brief with Marty, but antitrust enforcement, as important as it is, faces a number of challenges. It's hard to put the cat back in the bag. There's a bunch of other complexities about how to succeed in various antitrust enforcement activities. There's a lot of stuff that could be done that is good, but I think pretty clear that you're not going to solve the problem of high healthcare prices with simply antitrust enforcement. For that matter, I would say you're not going to solve it through a bunch of transparency initiatives, although we could debate the merits of transparency initiatives.
I'm with you.
Yeah, I think the fundamental problem is that in the extreme, you need to figure out what you want to stop and try and stop it. And we're proposing what I would call backstop price regulation. In other words, identify high prices and cap them. Our actual proposal has three components. One is capping high prices. I can talk more about the specifics if you want. The other one is cap the rate of healthcare price growth. And the third, which is probably more than we want to get into now, is a relatively squishy aspect of enforcement, and how you enforce this and the associated administrative costs really is a big deal. And we have some ideas about that, but I'm not sure that's been completely fleshed out.
So you want to regulate prices at 500% of the 20th percentile, if I have that right. How did you arrive at that? That's the cap.
Yeah, there's a few things. First of all, there's nothing magic about that. I'll explain how we got to it. The first point is why regulate is a multiple of commercial prices as opposed to a multiple of Medicare. There's a lot of people that are interested in regulating as a multiple of Medicare. So I omitted this from my introduction, but you know, Zach, I'm the chair of the Medicare Payment Advisory Commission. So the first thing is everything I say today in our proposal is a proposal for Michael as a professor at Harvard Medical School, not from Michael as the chair of MedPAC. That being said, I am very interested in Medicare policy, and my concern is that if we tie everything to Medicare policy, we connect all of the related debates about Medicare to commercial prices in the entire market, and it becomes problematic. Pressures to raise prices in Medicare will grow. It's very hard to understand how one would manage a number of challenges we're going to face in Medicare. For example, how we're going to deal with the trust fund if all those actions are going to be pulling commercial prices with them. So that moved us away from using Medicare as a basis for pricing. Despite the fact that using Medicare is by far the easiest thing for any state or someone else to do. Why we picked a multiple of a lower price is really basically because we wanted to start with a sense of where we thought maybe an efficient provider would be. We picked the 20th percentile. It doesn't have to be the 20th percentile. We picked it because loosely, and I use the term, very broadly, loosely the 20th percentile is where Medicare prices are. So while it's effectively similar to using Medicare prices, there's some differences. It is not mechanically tied to Medicare prices. It's also more nimble as there's changes over time. If Medicare prices, for example, for physician services, they're flat because of MAPRA, you would see them rising in the commercial market. So there's more flexibility there. And why 500% more? That's really just a choice between how much money you want to save and how heavy-handed you want to be in the market. We picked 500% because it gave us roughly 1% of savings. There's again some nuances there. I'm sure some people would criticize our proposal for being too timid. Others would criticize it for being too heavily involved in the government. I view it as a relatively pro-competitive model. I view it as that way for two reasons. One is it's based on commercial prices, and two is there's a lot of room for competition under these caps. The real goal is to try and cut off the top of the mountain where you think the most likely market failures occur. And I might add, the way we envision this is over time, you can nibble the prices down or loosen them up based on how you see the outcomes evolving. It's not like you have to pick one number and that's the prices forever. We do this all the time in Medicare, as we raise prices more than we thought, or we lower prices more than we're called for. And I think you can do that in the commercial side as well, based on some evaluations of where things are going. But we picked 500% of a low bound of commercial prices to give some room for markets to work, but to get rid of what we thought were most likely the most egregious problems.
I'm with you. So we put in your policy. You've done some simulations about savings. Can you just quantify those? Give us the sort of back of the envelope savings we could expect from your capping proposal.
Yeah, so these estimates are hard. The quick version is if you cap both inpatient and outpatient services only, you'd save about 1% of total spend. It's a little bit more, obviously, of commercial spend, because we're only at a little bit less than 4% of commercial spend. And of course, it's a little bit more if you look at just hospital spend. So as you change the denominator, you change the percentage. But if total NHE, it's around 1%. If you capped physician prices, which aren't as egregious you could argue how egregious physician prices are. They're not as egregious as some of the facility prices, but nevertheless, if you did a similar principle on the physician side, you get about another between 0.5% and 1% of overall spend.